I now welcome representatives from the Rural Health Workforce Australia and the National Rural Health Students Network. For the Hansard record, could you please give your name and the capacity in which you appear today?
My name's Greg Mundy and I'm the Chief Executive Officer of the Rural Health Workforce Australia.
Thank you, Mr Mundy.
And my name is Miss Danielle Dries and I am the Indigenous Health Officer for the National Rural Health Student Network.
Thank you very much, and just put on the record, congratulations on your presentation as part of the Closing the Gap gathering that we had on Wednesday morning here in Parliament. You represented young Aboriginal people with great style and content. Thank you.
Thank you very much.
Mr Mundy.
Our submission to the committee covered 5 key areas under your terms of reference, E and G, and I think it's appropriate at the outset to acknowledge that on one of those some progress has been made in terms of improving the way we classify rural areas in Australia. A long-standing issue is finally moving, and teething issues aside, appears to be moving in a positive direction. I think it's important to acknowledge that. I'm happy to respond to questions on any of the areas we canvassed, but I would like to focus, at least initially, on the first priority area for improvement of Indigenous and rural health services, which is developing the Australian trained workforce. Our submission refers to the need for a holistic, multifaceted approach to this, and I'd like to focus on the early stages of the workforce pipeline, as we refer to it, and in particular on Indigenous health professionals. And it's for that reason that I've invited Danielle Dries, who's already introduced herself, to speak a bit about the perspective of a young Indigenous woman who is a medical student with the committee, because she is in the early stages of what promises to be a strong and very worthwhile medical career. So if I could hand over with the committee's indulgence to Danielle.
Ms Dries.
Thank you. So I want to talk a little bit about the NRHSN and also my experiences. So the NRHSN has over 9,000 members at 28 rural health clubs across Australian universities, with students in medicine, nursing and allied health. We are currently in the process of developing our 2015 business plan, and our priorities for Indigenous health include improving communication and relationships with our key stakeholders, and this is acknowledging that Indigenous organisations need to be consulted to ensure that everything that we do is culturally appropriate. Another priority is increasing recruitment and retainment of Aboriginal and Torres Strait Islander students and health professionals. This is important, but what is crucial to this is the support of these students, because we can walk into an area where we're already in a minority. We experience racism and discrimination, but because there are few of us, there is often an expectation for us to become role models for the next generation, and we can be involved in many extracurricular activities, such as being here today. So support from organisations such as the Australian Indigenous Doctors Association, Indigenous Allied Health Australia and the Congress of Aboriginal and Torres Strait Islander Nurses and Midwives are important for us to provide a culturally safe community and support for our Indigenous health students. Having Aboriginal and Torres Strait Islander students also, I believe, helps to break down the stereotypes, to understand that there's diversity among our people and that we all come from different places. Many times people ask me, how would you treat an Aboriginal person if they came into your clinic? I usually respond with, well, how would you treat me if I walked into your clinic? And how would you treat me, and would you treat me the same as an Aboriginal elder? Probably not, but you are going to listen, show respect, and try to understand our individual story. This leads me to our next priority on our position paper, which emphasises the importance of Indigenous health curriculum across all university health degrees, as well as encouraging universities to run and participate in Indigenous health awareness events such as Close the Gap. Each year, our rural health clubs organise Indigenous community engagement activities. The aim of these is to inspire Aboriginal and Torres Strait Islander students to consider careers in health, as well as making healthy lifestyle choices. Clubs have also run or attended Close the Gap events, and these events aim to increase an understanding and develop culturally responsiveness early in our career pathways. Our Rural Health Club here in Canberra at the ANU Rural Medical Society runs a Close the Gap event every single year, and last year we had over 100 students from New South Wales, Victoria and ACT regions from different health professions. We are hoping this year that through the NRHSN we can encourage more students to attend and run these events to promote Indigenous health awareness and health careers to young people in a culturally responsive way. We are also hoping this year to advocate for more allied health professionals to work in the rural and remote setting. As I said on Wednesday, I was previously a physiotherapist and changed to medicine when I found that there was limited job opportunities in remote areas. Where there is chronic disease, we need allied health, and I think it is important to have these services available in rural and remote areas. Thank you.
Thank you very much, Ms. Dries, and I've got many questions that I'm sure I'd love to ask over a dinner. This is the wonderful thing about this job. We meet amazing people doing wonderful things. It's more that we'd love to know, and hopefully we might catch up with you further along in our journey. But I'm going to go to Senator McLucas right now for some questions. Thank you.
And thank you, Mr. Mundy and Ms. Dries, for your evidence. I totally agree, Ms. Dries, that we need more of you, because you're having to do all the things you do as a student and then all of this other stuff simply because you are an Aboriginal leader, young leader in the community. Where are you at uni?
I'm at the Australian National University in Canberra, but I'm currently in third-year placement in Lismore.
Oh, very good, very good. Thanks for your evidence, and I commend the work that you're doing in supporting students around the country. My university is James Cook, and you've got a really big RHWA. RHWA is the organisation in Townsville and Cairns, and they do some amazing work in promoting career opportunities for in health to Indigenous populations in North Queensland and further, in fact. I want to go to the question of training. So we get people to come into our universities and then they complete, let's talk about doctors first of all. They do their undergraduate training and then they need to be placed. That's where the PGPP program was particularly focused on ensuring that pre-vocational doctors get training opportunities in rural settings by and large. Mr. Mundy, did you have conversations with the government about why this program was cut? I think you were in the room when we spoke to Professor Campbell previously.
They did tell us why they'd cut it, which is not really the same thing as having a conversation. But I would agree with you that, and one of the points we've made in our submission is that to encourage young medical students to pursue rural careers, it takes persistence. The more exposure that people have to rural medicine, the more likely they are to continue their careers. And there's a lot of evidence, including a recent study published in the Medical Journal of Australia, actually focusing on the cohort of students from James Cook University, if I recall correctly, that says if students are from a rural background and trained in a rural setting, the statistical likelihood of them working in rural areas goes up quite a lot. And from our perspective, it's the continuity of that rural exposure is another variable, because if people have to go back to a city to complete part of their training, there is a risk, and some evidence that suggests that it does occur, of breaking that cycle, and you tend to lose a number of students who might have been potentially rural doctors. If you look at the data in our submission about the number of final year students who intend to pursue a career in rural medicine, it's actually quite low, and it's much lower than when they start, and it's partly because we think that people don't necessarily see a clear career path for them in rural medicine. We also refer very briefly in our submission to some research that we've commissioned from the University of Queensland about what factors early stage doctors and students take into account when they're making those sorts of career decisions, so that we can try and make some sense out of the correlation by saying, well, why is that so? It's early stages. We've only done the initial qualitative part of the research, but the thing that came through very strongly is the thing that early career medical students think about is their career. that they want to know that there's something to go on to, that working in a rural area is not going to compromise their aspirations, which are newly formed, and other things are important, but the things that come through very strongly is that they're going to be able to build a good, rewarding and successful career in medicine, and it won't be thwarted or compromised by working in rural areas. It shouldn't be, because the nature of the work in rural medicine is actually challenging, rewarding, broad-based, not overly specialised, has lots of positive things about it, which I guess is why people do it. But if that continuity is broken, you actually place that investment at risk. And we now have a large number of Australian medical graduates coming into the system. The figures in our submission represent a 64% increase over the 5 or 6 year period. That's a big increase. And I think as a nation, we can't afford to let those people down by, thwarting their careers when they come out. And we've invested a huge quantity of their money and public money getting to that point. So there's a question too about capitalising on that investment.
And with that increased pipeline, we still do have a lumpy geographical spread.
Absolutely.
And from our evidence we had from Professor Cameron, it would seem that actually the current policy settings are going to exacerbate those circumstances. If those graduating doctors are looking to country practice and saying, that's not a future for me.
Well, I don't think we can afford to be complacent. I mean, over a 10-year period from 2002 to 2012, the proportion of patients to doctors in remote parts of Australia has actually improved. So it's not all bad news. The ratio has gone down by about 400 patients per doctor over that 10-year period. So their progress has been made, but I think it's one of those things that you can't afford to rest on your laurels and be complacent. You have to understand what's made that success possible and what sorts of factors might place it at risk.
My final question goes to a program. Not a program, it's a piece of work that the Deans of Medicine are doing in tracking doctors post-graduation. Yep. It's got a name that I can't remember, and I am led to believe that piece of work has been defunded. Is that your... I will ask the department later today.
It's the Medical Schools Outcome Database project, and it was funded through Health Workforce Australia. The functions of Health Workforce Australia have been transferred to the Department of Health, so they are exactly the right people to ask. I actually don't know what its future funding position is. If it was a 2014-15 program, the question is what happens on the 1st of July this year, which is a question that many Commonwealth-funded organisations will face at that point, including us.
The piece of work you referred to earlier that
University of Queensland
UQ is doing, or was it James Cook is doing, about tracking people, would come out of that data?
Yes, it did. The James Cook cohort came out of the Medical Schools Outcome Database project.
I will ask the department about that later.
And the work that we're doing is rather looking at correlations, trying to make some sense of, well, why is that correlation there? What goes on in people's heads when they're making their career decisions? And that's a work in progress.
Great. Thank you.
Senator Cameron.
Oh, yes, thanks, Mr. Mundy, for coming along. And can I just put it to you, the proposition that Professor Campbell asserted, and that was that we've got a demographic time bomb in rural medicine in terms of the ageing of the workforce, and that we've got a policy crisis. Do you agree with those propositions?
We certainly have a demographic challenge in the rural workforce because the composition of the workforce is changing. There is a cohort of doctors who are getting closer to retirement. And the other demographic factor that's relevant is that the medical workforce across Australia, not least in rural areas, is also becoming much more evenly balanced in terms of gender. And the combination of those two factors from a workforce planning point of view is you actually need more doctors to replace the existing ones when they retire, because the newer generation of doctors are less prepared to work the excessive hours that the older generation of doctors does, and from an occupational health and safety point of view, that's a good thing, but it means if one of the overworked doctors retires, you might need 1.1 or 1.2 doctors to replace them, and it's a factual thing and not a judgmental one at all that the female doctors on a career average work a smaller number of hours, which is not a good or bad thing, it's just a thing. But it means you need 1.3 or 1.4 to replace one doctor that leaves. So although we have made progress, there's no room for complacency, because those changes which are just occurring in our society will actually increase the need for more doctors to be encouraged to work in rural areas. Is there an impending crisis? I was struck by the extent of the threat to business models in rural practice by the person who gave the previous evidence, and certainly that is a major concern. If we start losing practices for economic viability reasons, then there is a risk that much of the gains that I talked about before might be lost. And the point that Ms Dries made in her evidence that why she made a career change is that in very remote parts of Australia, private practice models are much less sustainable. You actually need an employer if you're going to be able to provide those services, when there's not a population either sufficiently dense or sufficiently affluent to support a private practice model, and if you don't have an employer, you don't have the service.
Yeah, and I should have acknowledged Ms Dries and thanked her for the effort she's put in to make the submission today. Has your organisation had any discussions with the Assistant Health Minister in relation to this demographic problem that we've identified?
We certainly have, apprised her of our views of that and had them acknowledge that, yes, those changes are occurring in the workforce, and that's why, the work that we do at Rural Health Workforce Australia is a very important part of the solution to that problem of increasing the flow of doctors into rural and remote parts of Australia. That's our role, and that's what the Department of Health funds us to do. So we've had that type of conversation with the Assistant Minister for Health.
And what is the Assistant Minister saying about the funding and the incentives to increase the workforce?
We haven't had specific budget type discussions, if that's what you're referring to, Senator. We do get the strong feeling that the Assistant Minister values the work that we do, appreciates the nature of it, sees the results of it in her own electorate office and so on. So we've had positive but not specific budget type discussions with Minister Nash. Everyone
seems to have lovely discussions with Senator Nash, but we don't seem to get any practical outcomes in terms of workforce planning or funding. You're the same, aren't you? You've had no commitments on funding.
No, not to date.
How do you then read the $500 million that's been taken out of essential services in Indigenous communities in relation to the last budget? Has that got health impact?
As an organisation, we don't have a formal position on that issue, but we wouldn't see that as being at all helpful in terms of improving health outcomes.
Right. I suppose, do you agree that poverty is a major issue in Indigenous communities and does contribute to poor health outcomes?
Absolutely. I mean, our role in trying to increase the activity of rurally based health professionals is a very important contribution to the health of those communities, but it's by no means the only one. And I think the figure quoted in early evidence just today, that 2/3 of the explanation lies outside of that in the social determinants of health, I think that's a good way of looking at it. So there's much more to improving the health of communities than what medical professionals can do and what we can do to support them. They're not entirely separate questions, but certainly things like poverty, education, good quality housing, ending family violence, none of those things are irrelevant at all, and in fact, put it the other way, are quite significant in creating health outcomes in all communities, but not least in rural ones.
So, what was your relationship with the federal body that was doing the workforce planning and assessment?
Health Workforce Australia. I suppose we were a consumer of their products in workforce planning, and our network of state-based agencies were also funded by or through Health Workforce Australia for the Rural Health Professionals Program, which was a program to increase the supply of allied health professionals and nurses in rural and remote parts of Australia. I think it was the first time there'd been a program with that as a strong target focus. At this stage, we anticipate that program will continue beyond the current financial year, but we don't have any confirmation of that. And I suspect, May the 12th will be the time when we know for sure that, that program is going to be extended. We think, and our submission says that it's been an extremely valuable contribution to rural workforce, and it should continue. As our submission says, and Ms. Dries has reinforced it, with the increase in the burden of disease coming from chronic diseases, the importance of allied health inputs to people's care is getting greater, not lesser. Not everything is done or can be done or should be done by GPs or by hospitals, but both in hospitals and in the community, what allied health professionals can do is a very important contribution. So that program, because it did target that area, is a valuable one, and we'd look forward to seeing it continued.
So, apart from getting some nice discussions with the Shadow Minister, have you got a nod and a wink that the programme will continue?
We haven't had any definitive discussions about the budget to this point.
Okay. I'm just wondering what you are discussing then, but thanks very much.
Thanks, Senator Cameron. Can I just go to a last question? There's much more, of course, we'd like to discuss, and if there is more material after you leave today that you would like to present to us, feel free to do that. We will be continuing our inquiry throughout the course of this first half of the year, and we may well see you again. Could I go to recommendation 6 with regard to the recommendations that arose from the last Parliament, the Lost in the Labyrinth report, which I had the privilege of being a part of that committee at that time, and amazing evidence given from right across the country about these critical issues of staffing in rural contexts, and also about, the experiment in overseas doctors, the impediments that that were placed in front of them in being able to access and support their communities, the varied success and failure of that program. In the context of that, and the recommendations that arose out of it, given what we've described about where we are today, could you make some policy connections between those two for us and articulate any big icebergs on the horizon?
Well, it's right to raise it because we've talked about the Australian-based workforce pipeline, but the fact of the matter is that rural Australia in particular would not have medical services but for overseas trained doctors providing those services. The average across Australia is about 42% of doctors in rural areas come from overseas, and in some states it's well over 50%, so that it's a very important current part of our workforce. It is a complex business. The legislation's complex, the rules are complex. One of the things that our state-based agencies assist doctors with is navigation through that system. It is overly complex. There are multiple decision points that are not coordinated between the various players in the system, and while progress has been made on some of the recommendations of the Lost in the Labyrinth report, I think most of the work is still in front of us.
Is it fair to say that that policy response that led to the whole overseas trained doctor program that has become so instrumental in health provision in the bush actually reflects a failure prior to that of an adequate training of the workforce, and the current policy settings of the government are actually recreating a similar policy crisis if they are enacted. If we fail to get, replace the PGPP, for example, if we fail to get the placement and training in order, we're creating a context where there simply won't be the provision of healthcare in the bush, especially in light of Professor Campbell's comments today about the sustainability of GP practices in the bush.
I think one of the things that pushed Australia in the direction of overseas recruitment was the Commonwealth's lack of power to indulge in what they call civil conscription of sending people to country areas, unlike states who can send teachers, for example, wherever they can get away with it. The Commonwealth lacks that power. So I think historically that was one of the factors that pushed us in that direction. There has been a policy response in terms of increasing the number and size of rural schools of health sciences and medicine, which I think is an important contribution to fixing that problem. So we've made some forward progress. But if we were, for example, to have a collapse in business models for rural general practice, such as the previous witness described, that potentially has the risk of setting us backwards quite considerably, because for the new graduates in medicine to have careers, they have to have people who've got practices that they can join, or if we're talking about salaried health professionals, they have to have employers who will employ them. So the viability of the businesses that provide healthcare in Australia and rural Australia, because they are private business, is actually a very important part of the picture. The public sector, which is the hospitals and in some states community health facilities and the Aboriginal health services that are publicly funded, are an important part of the equation. But the core of service provision is actually, if you like, private sector. They're private practices, and they have to be viable businesses if those services are to be provided. One of the services that our state-based agencies provide is often business support to those practices, but advice on how to do your accounting is not going to help if the numbers aren't going in the right direction. So we do have a private enterprise model of primary medical care in Australia, and it has to work on a business basis because that's its premise.
If we lose GPs from the bush, we're in very big trouble as a country, aren't we?
Yes, indeed.
And we look like we are on the precipice of that.
Well, there certainly are risk factors and risk signals out there that no one should ignore.
Thank you. I'm going to give the last word, if I can, to Ms. Dries. You're a young woman with a passion for your community, and I just want to give you the opportunity to make a significant recommendation that you think will change the future based on your lived experience so far and your hopes for the future in terms of the Aboriginal and Torres Strait Islander people. What's your most significant thing that you would like to see us recommend?
That's a big question.
You can write some more afterwards too, but I'll put you on the spot for an answer today as well.
That's fine. I would just definitely like to see that there's more of us. With more of us, there's more support, and there's a sharing of the commitments, and there's a sharing of the responsibility. And I think it creates a more culturally safe environment for everyone, because when you go into a university setting, you do challenge the thoughts of other people around you, and I think that is the future that I'm hoping that we get to. So I think with the recruitment of more students and the shared responsibility, I think that's where I hope we're headed.
I noted your comment about an Indigenous health curriculum, and I promise you that this afternoon I will ask a question of the Health Department about what is in train, what's the current status of Indigenous health training across the tertiary sector, and what the programs going forward might look like with regard to that. So thanks again. Congratulations on your journey so far, and good luck with being such a champion.
Thank you very much.
Thank you.
Thank you.